My name is Dr. Anton Fakhouri from Mid-America Hand to Shoulder Clinic. I would like to speak to you about Cubital Tunnel Syndrome. This is a common condition that we see in our practice. You may have heard of carpal tunnel syndrome, which is a compression of the median nerve at the level of the wrist. Well, this is similar, but involves a different nerve at the level of the elbow called ulnar nerve. The nerve is, if you can think of it as electrical wire, but it's soft and delicate. It looks like a long strand of spaghetti. So when you think about it, this particular electrical wire, this nerve goes through a very tortuous path. And when it gets compressed or irritated at the level of the elbow, which is the inside of the elbow, called cubital tunnel, then we call this condition cubital tunnel syndrome. The causes can be from prolonged elbow flexion, such as those who perhaps are on the phone for a prolonged period of time, or for example, those who drive with their elbow flexed for a prolonged period of time, those who do repetitive activities, perhaps a healed fracture, an abnormal position, spurs from arthritis, swelling, other conditions such as a cyst or lesions involving the inside of the elbow where it can compress the nerve. Any of these conditions can cause the nerve to become irritated and can be compressed, causing various symptoms. Well, what are the symptoms? The symptoms are very similar to carpal tunnel syndrome, but it involves different digits. The carpal tunnel syndrome specifically affects the thumb, index, and middle finger. Cubital tunnel syndrome affects the ring and small finger, although patients may complain of other digits involved. It also can cause numbness in the top of the hand. It can also cause weakness, specifically weakness of finger abduction as well as adduction of the thumb. This is the maneuver that it takes to grasp a key, if you will. With time, the muscle, which needs, if you will, electricity from that nerve, can undergo what's called muscle wasting or muscle atrophy. The symptoms include tingling, numbness, pain, and with time, they may actually complain of weakness. So how do we diagnose cubital tunnel syndrome? We talk to patients. We find out what their symptomology. Is it tingling, numbness? What area is involved? Do they have weakness? Do they wake up in the middle of the night with tingling and numbness? Which is not uncommon as people sleep with the elbows in flexed position. We test them. For example, one of the common tests we use is what's called elbow flexion test, where we ask the patient to flex their elbow and see if that provokes tingling and numbness in all the digits. We also test their strength. We may also get an X-ray of the elbow, see if there's spurs or other bony abnormalities that may be pinching the nerve. And some doctors will also order an electrical test called EMG to see if that elbow nerve is in fact sick, and to also test other adjacent nerves such as median nerve for the carpal tunnel syndrome. It's not unusual for patients to have both cubital tunnel syndrome and carpal tunnel syndrome. Once a diagnosis is made, then the doctor will implement various treatment modalities. One of the things that can irritate the nerve is for the patient to keep their elbow in a flexed position. So what we do is we order a splint to keep the elbow in extension, and patients can wear that at night so that it prevents the elbow from flexing. You can also order a pad to prevent any irritation or compression of the nerve. Medications such as ibuprofen and naproxen can also be helpful. Therapy can also be helpful. After a course of treatment, including splints and medication, therapy, rest, and time, as well as educating the patient in terms of avoiding provocative activities, then surgical intervention may be considered. That would be the last resort. The purpose of the surgery is to relieve the pressure off the nerve. Some surgeons will identify the nerve, remove it from its tunnel, the cubital tunnel, and move it anteriorly or forward in what's called transposition. Other surgeons, as myself, will do what's called medial condylectomy, where they identify the nerve, release the pressure off the nerve, keep it in the same site, but shave a portion of the bone. And in this particular scenario, I allow patients to use their arm for light activities the same day. They may type and write and pick up light objects. And normally we start therapy approximately a week after surgery. And there's no splints or cast afterwards. Gradually we can get patients back to their activities. If patients work in light activities such as secretarial work or non-laborious type of jobs, they may go back to work within a few days or a week or two. But if they have laborious jobs such as plumbers or let's say carpenters, it may take 2 to 3 months before we can get them back to full duty work. The results are good, and patients are generally quite happy with the outcome. For more information and to see more educational videos, please visit our website at handtoshoulderclinic.com.